all to our welcome you all to our regular weekly session. We are going to start a new session on breast cancer. This time we said that breast cancer management, how much we need to know. We have decided these topics because every day we are treating breast cancer patient. We are going through so many evidences, so many references, but maybe some small things that we are facing every day. We are struggling to get the answer. To find out those answers, we have designed this session. Here it will be a mixture of radiotherapy and also medical oncology, few surgical oncology also. So we will have 5 lectures on radiation oncology. Today is the first session on that. And as per culture, we are happy to have our President, Professor M.A. Hai, sir, with us. I will request Professor M.A. Hai to formally start the session, then we go to the session. So President, Professor M.A. Hai, sir.
Thank you, Kamal. Thank you, everybody. Good afternoon to everybody. Without any delay, I think we have already 20 minutes past. Start immediately without any delay.
So, as I mentioned, that today is our hardcore radiotherapy topics. Our topics is patient selection and treatment decision. We have 2 overseas faculty. One is Dr. John Conybeare, who is a consultant oncologist in Barts NHS Trust UK, and Dr. Anjali Pahuja, who is a consultant, Department of Radiation Oncology, Rajiv Gandhi Cancer Institute, Delhi. So, as I said, that we will be more talking on the issues, not on the theoretical things. So we requested Dr. Anjali to prepare a presentation which is more of addressing the issues like whom should we give radiation, how we should give radiation, whom we should not give radiation, and how to take a decision to radiotherapy after neoadjuvant chemotherapy, and few other issues will also come into discussion. So I will request everybody put your questions in the chat box, because end of the presentation we will have an extensive discussion to find out how can we solve our everyday issue. So Anjali, may I request you to start your presentation? Anjali.
Yeah, thank you, Dr. Kamal, and good evening, everyone. So I've been actually asked to cover a number of different topics in this presentation, ranging from patient selection to simulation to the right choice for immobilization, and then about DCIS, the need for regional nodal irradiation, and the need for deep inspiration breath hold technique. So my talk will be a mixture of what is there in the literature and what we do at our institute, not just following the guidelines, but sometimes you need to individualize as well, depending on the expertise you have, depending on the equipment, and depending upon an individual patient. So while I'm trying to start, actually, again, there is some problem here. The presentation is not opening. Just give me a minute. Okay, shall I?
Tanya, make Anjali co-host.
Yeah.
Make Anjali co-host.
Shall I start sharing?
Yeah, you can. Yes, now you can share.
Are the slides visible?
Yes, it is visible. Go to the slideshow.
Yeah. Okay, so these are the topics which we'll be covering. We'll start with early breast cancer. As we all know that for management of breast cancer, we divide it into early breast cancer, locally advanced breast cancer, and metastatic breast cancer. So what we are going to talk about today is early breast cancer and locally advanced breast cancer. So what is the basis of giving radiation in early breast cancer? We are all aware about the NSABP B06 studies that established the equivalence of breast conserving therapy and mastectomy in terms of local control and survival. And then there were further studies that demonstrated a threefold reduction in recurrence if radiotherapy was added after breast conserving surgery. So these were some of the landmark studies by Fisher et al., Veronesi, and Windsor, which showed that despite a low T stage, that is even in T1, T2 tumors, even in node negative patients, addition of radiotherapy after breast conserving surgery had a significant improvement in the locoregional recurrence rates. So breast conserving surgery was equivalent to mastectomy only if radiotherapy was added to the protocol. BCS alone could have a high locoregional recurrence rate. So local control will definitely be less if radiotherapy is not added. And then the subset of breast cancer, a subset analysis of those patients who underwent breast conserving surgery in the EBC-TCT meta-analysis also showed, this is a forest plot, which is showing that if this is the line of no hazard, then patients who received radiotherapy did better in across all these trials versus those who did not receive radiotherapy. Similarly, similar trend was seen in the breast cancer specific mortality as well, right? And some of these trials had a good number of patient numbers. So basically the conclusion of all these meta-analysis and randomized trials was that radiotherapy is a part and parcel of breast conserving therapy. This was again in the subset of patients who received radiotherapy in node negative patients. So you can see the difference in the local recurrence rates as well as in the breast cancer mortality rates. And this was in the patients who had a node positive disease. Definitely the impact was more in, the impact of adding radiotherapy was more in node positive disease patients. So the advantages of breast conserving therapy as propounded in literature are that it has minimal long-term complications, it has favorable cosmetic outcome, and therefore reduced psychological trauma on the patient. In all, it comprises of resection of the primary breast tumor, which can be in the form of a lumpectomy, a segmental mastectomy, or a wide local excision, followed by whole breast irradiation and tumor bed boost. The fractionation that I have mentioned here is the standard fractionation which was in vogue for many, many years. It is being gradually replaced by hypofractionation across many centers after the publication of START-A and START-B trial, but I think there is a different lecture on dose fractionation altogether. So I'm not going into the detail of dose and fractionation as of now. So this was a brief evidence to support the use of radiotherapy in early breast cancer. And now we come to locally advanced breast cancer. So broadly, the indications of post-mastectomy radiotherapy are if there are 4 or more involved axillary nodes in the pathological specimen, T3 tumor, or T3 or T4 tumors, and operable stage 3 tumors. Some gray zones are, which have been gray zones for many years, and they've been the topic of debates for many years, are T1, T2 tumors with 1, 2, 3 positive axillary nodes. And after after neoadjuvant chemotherapy, if complete response has been achieved, then is there a real role of PMRT or not? The evidence for post-mastectomy radiotherapy comes from 3 meta-analyses, from 3 randomized controlled trials, namely Danish group trials and the Vancouver study, and the ongoing Supremo trial. So PRIMO trial is one trial whose results are long awaited, but as of now, we have received the interim results pertaining to quality of life issues. The results related to local control and overall survival are still pending. The benefits of adding radiotherapy after mastectomy include reduction in the risk of locoregional failure, thereby reducing physical and psychological morbidity. A potential benefit could be reduction in the risk of distant relapse and death if a good local control is achieved. So the evidence for this again comes from the EBC-TCG meta-analysis in the mastectomy subset of patients. Patients who had positive axillary nodes showed a definite benefit with addition of radiation in terms of local recurrence, 20-year breast cancer mortality, and any cause mortality. Patients who had only 1 to 3 positive nodes also showed a benefit. And patients who received proper systemic therapy also showed benefit in terms of local control. More than 4 positive nodes definitely benefited from addition of radiotherapy. Okay. Can we stop these pop-ups? It keeps telling me someone is waiting in the waiting room, entered the waiting room for this meeting.
Anya, don't just allow her to share and don't make her co-host. Okay, please, Anjali, continue.
What is the need to tailor therapy with respect to PMRT? I mean, why don't we just decide to give radiotherapy to every patient? Why is there a need to tailor the therapy? Okay, now I'm not able to proceed with the presentation.
Tanya, allow her to share the screen, not co-host, but allow her to share the screen. Permission to share the screen. Is it okay now?
It's not moving. Okay, you can make me the co-host, no problem. I'll
make her the co-host. Make her the co-host. Okay, please proceed.
Okay.
ভালো যে উপরে থেকে দেখো তার এটা আছে অ্যাডমিট করতে মানে মিটিং এ ওই জিনিসটা মানে মাফ করতে যাচ্ছে
বুঝছি স্যার. So can you move it now, Anjali?
Okay. Thank you. So why is there a need to tailor the delivery of post-mastectomy radiotherapy? Why can't it be just given to all the patients? Why do we need to select the patients for post-mastectomy radiotherapy? The reasons are when we add radiation to complete axillary dissection or even level 1 and 2 axillary dissection, there are higher chances of lymphedema. The duration of treatment goes beyond, I mean, it can increase by up to 3 to 4 weeks, sometimes even 5 weeks. It definitely has an impact on the finances, on professional obligations of a lady. There are logistic issues because radiation facilities may not be located close to the hometown, and an impact on the family life as well. So that is why we need to select patients for post-mastectomy radiotherapy. The traditional parameters have been, as I told you, T3, T4 tumors, positivity of regional nodes, and if axillary dissection has been incomplete, right? So when do we treat the regional nodes? The strongest evidence came from MA20 intergroup trial, which randomized high-risk women defined by positive lymph node and negative lymph nodes with high-risk features, who received breast conserving therapy in the form of whole breast irradiation with or without regional nodal irradiation. And it was seen that inclusion of regional nodal irradiation improved the loco-regional DFS, distant DFS, and trended towards a statistically significant improvement in the overall survival. The rate of lymphedema was definitely more when regional nodal irradiation was also included. So if we have to consider regional nodal irradiation, then what I'm showing you on this slide is something that we follow at our institute as well. We include all the levels, that is level 1, 2, and 3, when there has been inadequate axillary dissection. This is often the case when a patient has been treated in a non-oncological institute, is not keen on undergoing a complete axillary dissection and just wants to proceed with the adjuvant treatment. So in that case, we do include all the levels. If a patient has N3 nodal disease or N2, N1 with extracapsular spread, we include only level 3 and supraclavicular fossa, that is the undissected axilla and the supraclavicular fossa, in patients who have up to 3 positive nodes in an adequately dissected axilla. Okay, so the patient has undergone proper axillary dissection and histopathological report shows up to 3 positive nodes. We include only the undissected axilla and the supraclav fossa in the field. Supraclavicular fossa with posterior axillary boost was considered when we used to treat patients with 2-dimensional techniques and who were obese or had heavy nodal positivity, where we knew that a single direct field will not be able to irradiate the nodal regions properly. Complete omission of regional nodal irradiation. We consider that in patients who are node negative in a properly dissected axilla after breast conserving surgery or modified radical mastectomy. So in these cases, we treat only the whole breast or the chest wall. So if you see the guidelines for post-mastectomy radiotherapy, the ASCO guidelines, when published in 2001, and then again the latest ones being in 2017, the differences have been that in 2001, there was insufficient evidence to make recommendations for routine use of PMRT in patients with early breast cancer otherwise, but 1 to 3 positive nodes. However, in 2017, the panel unanimously agreed that there is available evidence that PMRT reduces the risk of locoregional failure and breast cancer mortality in even 1 to 3 positive nodes. There was insufficient evidence to state whether a supraclav field should or should not be used in 1 to 3 positive nodes. But in 2017, the recommendation was that the minimum mandatory target volume for PMRT are chest wall and supraclavicular and level 3 axillary lymph nodes. In 2001, the majority concluded that patients who require mastectomy after systemic therapy should receive PMRT. In 2017, it agreed that patients with persistently involved nodes on axillary lymph node dissection have a sufficient high risk of locoregional failure and should receive PMRT. So this we are talking about PMRT after neoadjuvant chemotherapy. So further slides are going to address that issue as well. So this is something new that the traditional parameters to decide the need for radiation have been primary tumor size, margin status, number of involved nodes, extracapsular extension. Some oncologists even consider lymphovascular space invasion as a parameter for high chances of locoregional recurrence. Now, in the era of personalized medicines, we need biomarkers that are clinically useful and can be linked to a specific therapeutic intervention. We do have that when it comes to choosing chemotherapy or immunotherapies. But for radiation, these are still in a very infant stage where a lot of literature is coming up on radiation omission signatures, radiation induced gene signatures, radiation intensification signatures, and tailored radiation signatures. So these are certain genetic markers that are being studied and validated to select patients for the need of radiation, whether they need some intensification of radiation, and whether some patients can be completely when they can just we can omit radiation for them despite the traditional presence of traditional parameters. So this is about need for post-mastectomy radiation after neoadjuvant chemo. Neoadjuvant chemo can change the pathological disease in about 80 to 90% of the patients. It is unclear whether how the NACT pathological information guides decision regarding RT treatment. This is still a gray zone in management of carcinoma breast. It has been seen that up to clinical stage 2, we are talking about the stage group 2, patients who achieve a lymph node negative status have a less than 10% risk of locoregional recurrence in the absence of radiation. Whereas those who have residual disease, that is YPN1 onwards, after NACT, the risk of locoregional recurrence is greater than 15% if radiation is not added. So these are some of the ongoing trials with respect to neoadjuvant chemotherapy and the need for radiation. In clinically T0 to T4 disease, N1 to N2, treated with neoadjuvant chemo, they've undergone sentinel node surgery and then completion axillary node dissection if node was positive. And then RT has been given at discretion of treating physicians. We are looking at the patients who've undergone mastectomy. Okay, so this is a group of patients who've undergone mastectomy. This is the locoregional recurrence, disease-free survival, overall survival, and the breast cancer specific survival in patients who received radiation, and the same parameters in patients who did not receive radiation. So you see there is a trend towards better outcomes in patients who have received radiation. Similarly, in patients who've undergone breast conserving surgery after neoadjuvant chemotherapy, with respect to regional nodal radiation, because the breast has to be treated anyways if it is a breast conserving surgery. So we are here comparing the need for regional nodal radiation. Again, the same parameters. The trend is not much different. In fact, if you see, there are certain parameters where giving RT and not giving RT shows better outcomes. So here there is a kind of, you can say, a dichotomy, I mean, whether it should be given or not given. We're not very sure. In patients who have received, who have achieved a complete N0 status. But in patients who do not achieve a N0 status, giving regional nodal irradiation has a significant impact in overall survival and breast cancer specific survival. So these are the some of the ongoing trials, NSABP B51 and the Alliance trial, where the need for radiation after neoadjuvant chemotherapy is being studied. Now we'll move to ductal carcinoma in situ. The things were simplified after the publication of the Van Nuys prognostic index in ductal carcinoma in situ. This was after the publication of the trial, it was much simpler to choose patients for adjuvant radiotherapy in patients who have undergone breast conserving surgery or for ductal carcinoma in situ. The scoring goes this way. These are the 4 parameters: size of the lesion that has been removed, the margin status, the pathological classification based on grade and necrosis, and the age of the patient. So each parameter has a score from 1 to 3. So smaller the size, the better. More the margin, wider the margins, the better. Lower grade without necrosis, again better. And age more than 60 is better. And as we move away from these parameters, the score goes increasing. So now for low grade lesions, that is patients who achieve a score of 4, 5 or 6. For them, things are pretty clear. They are not likely to receive any significant benefit from giving radiation after breast conserving surgery. At the other extreme are patients who get a score of 10, 11 or 12. That is the high grade lesions. These patients theoretically should achieve the absolute benefit from post-excisional radiation. But despite adding radiation in these patients, the local recurrence rates continue to be very high. So in these patients, the ideal recommendation is actually to go for mastectomy. It is the intermediate grade lesions, that is 7, 8 or 9, where patients with a margin score of 2 or 3, that is 1 to 9 mm margin or less than 1 mm margin, re-excision may actually lower their prognostic index. They may come down to this score, right? And therefore, radiation may not be required. However, even after re-excision, if the patient remains in the intermediate score, then radiation therapy should be considered. So it is mainly the intermediate grade lesions where addition of radiation after ductal carcinoma in situ has a role to play. And regional nodes are not addressed. Patients do not require an axillary dissection, and we are also not including the regional nodes in our radiation field for DCIS. So now coming to the radiation volumes, the contouring part and the radiation volumes are being taken by a different person. The reason I have included this slide is to basically maintain a continuity for the simulation part, why we simulate or position a patient in a particular way. So the areas to be planned in a post-mastectomy radiotherapy patient or a breast conserving surgery patient is chest wall or whole breast, the axilla, the supraclav field, and the internal mammary node sometimes when indicated. The basis of positioning a patient in planning, we are talking about 2D planning right now, that all the areas which I just highlighted here, which need to be planned, should be clearly visible, and there should be no skin folds in those areas. Okay, they should be easily, it should be easy to set up, and the patient should not be uncomfortable in holding a particular position. So we need to read the imaging and the histopath report properly. We should understand the patient's body habitus. We should check for the arms movement, very important, because sometimes patients are not able to abduct their arm properly, right? So a comfortable position for the arm has to be maintained. If there is any lymphedema at the time of simulation, please document it. The body mass index, this is basically about the body habitus. The type of breast, whether it's a very pendulous breast or whether it's a normal breast, that has to be documented. And the location of the tumor, in case a boost has to be planned. So this is the most commonly used position. That is, the patient is placed supine with the head turned towards the opposite side so that the supraclav fossa, there are no skin folds, and the ipsilateral arm is abducted and raised above the head. So here you can see that all these areas are well exposed, and this position is usually very easy to maintain, especially if this kind of a breast board has been given, or if this kind of a support can be given to the hands. In 2D simulation, again, before we start planning or marking, we have to place certain radio-opaque markers. One is in the midline and the other one is in the mid-axillary line. And this helps us to plan the entry points for the tangents. These are certain typical, atypical conditions where we need to change the protocol. This patient has to be placed prone. Sometimes even lateral decubitus position is used if the breast is pendulous. And posterior axillary boost, in case that needs to be planned, the patient has to be planned in a prone position, because here it is the bony landmark of scapula that helps us in planning the fields. The forearm has to be rotated downwards and the shoulder tip has to touch the tabletop here. So this is just to show you how the prone position helps in planning and keeping the high dose color wash away from the cardiac region, right? So you can see the difference here. What we are now commonly doing is volume planning after a CT simulation. Positioning the patient in a supine position using a breast wedge sometimes. Both the arms are placed above the head. The patient has to be in the center of the table unless the breast to be treated is too large. In that case, we can shift the patient slightly, make it off center. We acquire a scout film of the entire chest area to make sure that the patient is straight and there is no rotation. Then radio opaque markers are to be placed along the clinically palpable borders of the breast. Okay, this is very useful when we are doing a target delineation, that is the whole breast volume. So clinically palpable tissue of the breast should be marked with radio opaque markers. One thing you should be careful about while choosing radio opaque markers is that the marker themselves should not be throwing too much artifacts. Okay, if the wire itself is made up of a material where it is giving off artifacts, not only will it make delineation difficult for you, it will also lead to erroneous calculation by the system. Okay, scar on the nipple of the opposite breast and just the provisional field borders. We sometimes we give an IV contrast. The scan is acquired from the chin up to 5 centimeters below the breast region. It's a 3 to 5 mm scan in free breathing, if not doing DIBH. Positioning uncertainties patient. These last 3 points actually remain valid for not just simulation, but even during treatment, we have to assess for any weight loss, any change in body habitus, and how the patient is on the couch, not be uncomfortable for any reason. Okay. Okay, so after this, we are coming to cardiac toxicity and the need for introducing DIBH. So if you see the results, 20-year follow-up of NSA BP B06 study, we saw that the disease-free survival, though there was some improvement, but the overall survival did not show much improvement. And the improved local control did not translate into improved overall survival. The probable reason was long-term cardiotoxicity caused by irradiation of the heart in the left-sided breast cancers. Breast cancer showed that left-sided radiotherapy compromised long-term survival at 20 years. So this knowledge of risk of cardiac toxicity and the resulting importance of cardiac sparing led to certain innovations in planning left-sided breast cancers. These are some of the various methods by which we try to minimize cardiac toxicity. One is introduction of partial own. So I will not go into the details of requirement for one of the earlier slides, how we are able to reduce the cardiac dose, breath hold techniques, respiratory gating technique, and proton therapy. So this is one example of partial breast irradiation. And this is planning the patient, let's say same patient when planned in supine position or in decubitus position. You see there is significant sparing of the cardiac tissue here, especially the region where we mark the anterior descending artery. And this is in prone position. About DIBH, it is for the PG students here, it is deep inspiration breath hold. So as the name suggests, the planning CT scan is obtained with the patient holding her breath comfortably in deep inspiration. Okay, the idea is that the patient should hold it to that much depth where she can hold it for at least 20 to 30 seconds. Okay, extreme inspiration may be possible for about 10 seconds or so, but then slowly she will comfortable level. Okay, and the treatment is delivered in 20 to 30 second slots of breath holding, between which the patient is able to breathe freely. So this is basically a gated kind of with her breath hold pattern. To go into the expiration phase, the radiation beam is switched off. Okay, automatically gets switched off. When the patient is again asked to take a deep breath and she reaches that particular set level, the beam is on. Okay, so what you see here, this is what we see when the patient is in free breathing. The cardiac tissue is very close to the chest wall here. And the planning target volume is bound to overlap with the cardiac region. When she takes a deep breath, the chest wall moves away from the heart. And so the planning target volume will come somewhere here, and the cardiac tissue is likely to receive a lower. A much lower. The green the high dose region, the heart is in the low dose region. Okay. So inspiration increases the separation between the heart and the left breast, or the very big advantage we're able to use because that reduces the treatment time significantly. And it also reduces the dose to the opposite breast, to the opposite lung. So this is just in a tabular form, published in 2015 by Roche et al. With respect to cardiac parameters, heart, left ventricle, and the anterior descending artery. There is a significant reduction in the mean doses of heart, of the left ventricle, and the anterior descending artery, and also even the lateral lung. The reduction is also seen in the low dose as well as the high dose parameters. I have tried to cover all the topics. Questions now or any discussions?
Thank you, Anjali. I think you have covered whatever we asked. And as you said that we are going to have 4 more lectures, one on contouring, one on different type of planning and hyperfractionation, then plan evaluation, treatment delivery. So we will have more to discuss. So today, I think we can start the discussion. I don't see any question in the chat box. All the participants are requested to put their question in the chat box, or you can raise your hand. So John, at the beginning, would you like to make some comments on the presentation? John.
Hi, yes. So excellent talk. I think you've really covered, all the groundwork when it comes to the use of radiotherapy in early breast cancer. And clearly it's becoming ever more complex as the strategies we employ to treat patients optimally evolve. So now in the era of neoadjuvant chemotherapy, with new drug agents coming into the fold, which again may influence the radiotherapy that we deliver, both in terms of dose and toxicity. I think one of the things personally I find a challenge is the post-neoadjuvant chemotherapy patients and making decisions on radiotherapy for those particular group of patients. And so those with minimally residual invasive disease, for instance, post-mastectomy, in the context of patients, for instance, who've got therapeutic effect in lymph nodes, but no positive disease left in the lymph nodes. And again, it's real world MDT discussions that pose a challenge, I find. But yeah, excellent talk.
So thanks, John. There is a question in the chat box. In case of tumor of upper inner quadrant, what about the nodal radiation recommendation? So it is Dr. Shajol, I think he has asked the question. Anjali, would you like to answer? Upper inner quadrant.
Yes, I think I did not cover that in this slide. We are including the internal mammary nodal chain in inner quadrant, whether upper or lower, as well as central quadrant tumors.
So the next,
in addition to the undetected axilla.
Great. So I have few questions. So what we can say that when we are dealing with breast conservation, irrespective of size or nodal status, we cannot avoid radiation. That is the bottom line. I mean, we need to give radiation with or without nodal irradiation. That is the question. But under any circumstances, there is no situation probably that where we can avoid radiation in breast conservation. Am I correct?
There is one very small subset of patients who will probably be considered after the prime 1, prime 2 results was ladies more than 70 years of age with T1, T2 lesion, node negative, ERPR positive, HER2 neu negative, and no lymphovascular space invasion or other known high-risk features. Those are the ladies where we sometimes do offer observation. I mean, no radiation, but they have to take the hormonal treatment.
Okay. So that's why I tried to mention, because in principle, what we know that when it is a mastectomy, we have a subset of patients where we can avoid radiation, but in breast conservation, as a rule of thumb, we need to give radiation. This is a very exceptional case after the prime 1 trial came. And still they are telling there are some risks, but the risk is not that significant. So considering the age and all this tumor biology, we can avoid. So the next question is that regarding the boost, John, this is a planned question for you. We always see the boost is 10 to 16. Where is the magic number coming from? 10 and 16. Where we give 10, when we give 16? What is your practice?
So interestingly, I kind of fall between those. So as you know, the UK's made a big jump towards using fast forward. And so after 26 in 5, we now routinely use 10 in 5 as our 2-grade refraction post whole breast dose. And so in BARTs, for patients who had the more classical fast 40 and 15, we'd normally use 12 in 4, so 3-grade refraction. So we haven't, in our center, we haven't routinely used 16 in 4. We've always used 12. The other thing that we're moving to, and I've recently done, is simultaneous integrated boost. So 48 grain 15 to the tumor bed, and then 40 in 15 to the surrounding normal breast tissues. I don't know if many others on the call are using simultaneous integrated boosts in their patients.
So Anjali made a good points about the DCI story where we can avoid, but is there any situation in invasive breast cancer after breast conservation whether we can avoid this boost? Is there any situation?
In invasive breast
Yep.
cancer, sir?
Yes, in invasive.
Okay. Actually, we are planning a boost. We are planning a boost in patients who are less than 50 years of age or have grade 3 lesions, grade 2 or grade 3 lesions. So, ladies who have a grade 1 invasive breast cancer or more than 60 years of age can be omitted from the boost. This is from the last ASCO update. I think there were very clear-cut recommendations for planning a tumor bed boost. Age less than 60 or grade 2, grade 3 lesions are the ones which should be considered for a boost.
Okay. So one interesting, my question is for the PMRT, to get the bolus. So what is the culture of Rajiv Gandhi? How many fraction? 50%, all, 2/3? How much fraction you go or no bolus?
Yeah, we are actually using a bolus for 1/3 of the treatment. Actually, earlier we used to put it for half the treatment, 50% of the treatment. But with the increasing use of IMRT and the fact that the patient is wearing an Offit cast during treatment, which already has a thickness of about 2 mm. Putting the bolus for 50% of the treatment was leading to higher grades of dermatitis during treatment. And especially when we switched to hypofractionation, we are doing hypofractionation for post-mastectomy patients. So there, the treatment was a bit too toxic for the skin. So we usually now remove the bolus after 1/3 of the treatment.
So John, what is your practice for bolus?
So in Bart's post-mastectomy, we actually use brass bolus. We call it bling because it looks quite shiny and metallic, and it's a bit like brass chainmail. So we apply that to the skin surface, and patients wear that throughout the full course of radiotherapy. So patients who have inflammatory breast cancers, when they present, then I normally fully bolus the skin after they've had their mastectomy. But towards the end, I just watch very carefully for skin toxicity, and if necessary, take the bolus off if they're developing significant skin ulceration, desquamation.
Okay, Anjali, about the triple negative breast cancer, PMRT, we know that early T1, T2, and 0, we can avoid PMRT, but in TNBC, in your center, are you practicing post-mastectomy radiotherapy even in early stage or not?
Yeah, I'm sorry,
Anjali, are you
the
there?
voice was breaking, but if I understand, early stage and TNBC.
Yes, early stage TNBC, T1, T2, and 0, early stage PMRT.
Yeah, okay. No, we are not considering triple negative disease as a marker for systemic failure, we believe. So we are not considering them for PMR.
Okay, so this is a debatable area. So John, Anjali was telling that even in dissected axilla, when there is N3 disease or in TN1 with extranodal extension, they are still trying to address the axilla. Are you doing the same? Because I have the surgery is done by the best breast surgeon.
I personally don't normally include the axilla as well if they've had a full surgical dissection. I normally avoid the axilla and just treat the SCF, chest wall or recon or breast, and then IMC depending on the overall nodal stage and characteristics of the tumor.
Sorry, I think I was a bit disconnected. So Anjali, my question was normally in N2 and N3 disease, even a good surgeon has done the breast surgery. In your center, are you treating the axilla? I think what you tried to mention in the presentation.
I'm sorry, I didn't get the question. The voice is breaking. Could you just come again?
Sorry?
Sir, could you repeat?
It's a surgery done by a good oncosurgeon and the node is N2 or N3. Will you be still treating the axilla or not in your center?
We'll be N2 or N3. We are treating only the undissected axilla, supraclav fossa. But if N2, N3 is associated with extracapsular spread axilla.
Okay, so you are treating the axilla. If there is extracapsular spread, then even in dissected axilla, you are giving radiation.
Yes, yes. We call it comprehensive axillary radiation. So we are doing that if there is extracapsular spread with N2, N3.
John, any comment
If
on
there
this?
is no
So we treat much less axillas in our practice. So typically we only treat the axilla if they haven't had axillary surgery, despite being node positive. So they will have had a discussion about going back post-sentinel for axillary dissection versus RT. And to be honest, I'd say the majority of patients go back and have a full axillary dissection rather than having post-surgical radiotherapy, which may be controversial given the results that exist. But I don't normally treat patients with axillary radiotherapy if they've had a full dissection. I also find it very interesting, the idea of extracapsular extension. What does that really mean? Does that mean it's extended into the fat that surrounds the lymph nodes in the dissection specimen that's under the microscope? Or does it mean that it's a true R1 resection and that there's disease left behind in the patient at the borders of where they dissected the axillary nodes? So again, it's clarification through discussion with your histopathologist and surgeon what that truly means. Because if there is residual disease, then I will, of course, include that in my volume.
This is a topic where the radiation oncologists can have a debate amongst themselves.
Definitely.
Yeah. So one question. Anjali was talking about the bulky patient and heavy burden for posterior axillary boost. But what about a nice patient, but unfortunately there is a supraclav node? So when we are treating the patient, how we are going to, is there anything special that you suggest when we find clinically there is a supraclav node and we found FNSC is positive, but definitely we are not going to dissect it. We have done the axillary dissection and everything is done. So during radiation, is there any special maneuver you will suggest because there is a supraclav node positive? John.
So, presuming they've had their full staging to make sure that they have, N3 SCF nodes, then I will make sure that when we treat it, it'll be contoured and included in the treatment volume. And what's interesting is, so is the node cytologically positive before neoadjuvant chemotherapy? Because if someone's got an SCF node in our practice, typically they're going to be going through for upfront chemo first, and then they'll have pre and post chemo imaging to assess response. It would be unusual, I would say, for patients in our practice to have SCF positive nodes post surgery and then be coming in for radiotherapy in that state. They would have had some form of systemic chemotherapy, but essentially, long story short, I would probably boost it if they've got macroscopic disease that can be seen on imaging. So it wouldn't get an adjuvant dose. I'd give it a full fat macroscopic disease RT dose. Does that answer your question, Kamal?
So Anjali, it is not a common thing, but sometimes we find this type of situation, funny situation. There is axillary in a supraclav node sitting there. So how do you address? Do you want the surgeon to take it on, or you give electron, or you just cover the supraclav?
Actually, this is, we do encounter this situation, and usually these patients come to us after neoadjuvant chemotherapy. The patient would have received NACT, operated, and the SCF has not been touched by the surgeon. The interesting thing is that if the patient has achieved a complete clinical response, the SCF node will not be visible in our planning CT scan. We are doing all volume-based planning. So when we do a simulation CT, this node will not be visible. So here is the importance of registering our planning CT with the baseline PET CT that has been done. That shows the node very clearly. Secondly, what we tend to do is we include we demarcate that lymph node with the help of PET. We also demarcate the region, the supraclav fossa, ipsilateral supraclav fossa, include that in the elective nodal region. And the node is further given a boost of up to 50 to 54 Grays. We are usually, now that we are doing volume-based planning, we are not using electrons these days because that introduces the problem of matching. But yes, when we were doing simulation by 2D era, 2D technique, that time we were using electron boost for such undissected lymph nodes.
John, this was the issue because Anjali and me, we sometimes find this type of patients, and the culture is to boost the node. That's what I wanted to hear. Probably you are fortunate not to see this type of patient, but we see, as she said, it comes after the neoadjuvant chemotherapy. You can put the finger, you can just feel it. It is there. And then it becomes a challenge whether to ask the surgeon, and it was not dissected. So probably we don't know. I have no literature about it, but I see, say, many colleagues are doing the boost, and probably they are also doing the same. So
I would do a boost.
You will do
the doses that we use. They're adjuvant microscopic doses. If you've got SCF nodes, just like doing head and neck cancer, you wouldn't use an adjuvant dose for head and neck if you've got residual confirmed macroscopic disease. So I agree, but give it higher.
So John, this is the era of hypofractionation. We will have the next session, third session on time. Just one quick question from Dr. Arman. Is there any situation where we should not go for hypofractionation, but we should go for conventional fractionation? Is there any situation? In the era of fast forward, I'm asking you a funny question.
So there, UK is fully embraced 26-in-5, and we use it a lot. There's times where I I roll it back. So obviously changing to a lower dose per fraction is kinder to your organs at risk, and you're more likely to meet your constraints. So if I can't meet the constraints, then I won't compromise coverage. I'll change my dose fractionation. I'm also nervous when it comes to autologous reconstructed tissues. So if they've had a DF flap reconstruction, for instance, I won't use, or I normally don't use 26-in-5. The other thing is, if they've had some form of prior radiotherapy in the past for something, then I'll stick to 2 gray per fraction rather than 2.67 or higher. So, you know, some patients might have had mediastinal radiotherapy for Hodgkin's in their youth, and therefore I'll adapt. 2 gray I think is the safe way to approach it if there's any controversy or concerns.
So thanks, John. I mean, it is very important that we are moving towards hyperfractionation, 50 to 40, 40 to 5/5. But we should remember that maybe there is some situation where, as he mentioned, that when we need to do a trade-off between the OAR dose and our target coverage, then we can ask the physics, okay, why not you try with 50, 25 fraction by 50 gray, and can you achieve it? Because end of the day, we want to have a good coverage with the safety of the OAR. Because now what we are doing the trade-off. We are just forgetting the IM node and just covering. Well, 70% take it because I don't want to give more to the heart. But there is some situation where we can think about going back to the 50 gray 25 fraction, as John said, that if in a very special cases for the contour or for some situation, we are not achieving the OAR dose and the nodal dose, maybe we can think of these things, not every day, but we should not forget the old friend of 50 gray in 25 fraction. Thanks, Arman, for bringing a very interesting thing, because when we go forward, we forget the past. That is not good. My last question, because we are almost near about 5 o'clock, we are supposed to finish at 4:30. My apology, because today when we send the message, I think there was some technical issue in the email, so many of our colleagues could not join. Hopefully next week we will sort it out. And for this technical reason, even our faculty was delayed to join, so we started late. Venue index is a very interesting thing, and it was validated. But unfortunately, it is not widely practiced. I mean, if we practice, maybe we can avoid, but we are scared because when we are doing conservation, DCIS, not giving radiation, so hesitancy works. But I know it is a totally validated protocol, I mean, the nomogram. So what is the, are you using it, Anjali, in your center routinely when you index for DCIS?
Yes, sir. We are using this index for choosing patients for radiation. Our surgeons are sending us every patient after the surgery. So we do tell them the pros and cons, and we are using it for selection of patients for radiation. Actually, the thing is that even this is not usually all in black and white. Even this index has its own limitations. But thing is, it has simplified things a lot. And it's easier to explain to a patient that, see, you are in this category, you will not benefit or you will benefit, like that.
John, are you using venue index for the DCIS?
Yeah, we use it routinely. Yeah.
So in our practice, don't know about other colleagues. If it is a mastectomy, I'm happy, no radiation. If it is a conservation, then I decide boost or no boost. I hardly don't think about radiation because reflectively, I just think that it is a conservation. Well, venue index, as I mentioned, is not a common practice by me at least, but it is a validated tool. It can be used, and both of our colleagues are using. So it is a message to our colleagues in Bangladesh, because we have a heavy burden of radiation, long waiting time. I mean, if we can avoid few patients from radiation for no benefit or very little benefit, it will be a help for others who are in the waiting list. So thank you very much to both our faculties Anjali, it was a great talk. What John said, you have covered so many things in a very precise way and exactly what I wanted. I didn't want many data, but I wanted the decision that what is really need to be done. Because these are the very small things that every day we are struggling. And with these small tips, maybe we can improve the quality. And we believe radiation is still, I mean, when on chemotherapy, we are going to the molecular level, molecular signature radiation, still we're struggling to with the best even in the 2D, where we have so many fantastic things. To deal with so many high-tech things, we need to be very cautious and very keen. Sometimes in an excuse of hurry, maybe we are not doing it. And personally, I think people think that breast cancer is the most easy to treat in radiation, but I think the most difficult radiation in the whole body is breast, from 2D to VMAT. When it is 2D, matching is the issue, and VMAT, the low dose is the issue. So issue is always chasing us in breast cancer. In other side, when we are having the higher technique, it is saving us from many other things. But breast, I mean, somehow or others, even in every technique, there is a big challenge to ensure the best quality. On the other hand, you see the significant contribution of breast radiation. So we cannot just ignore it. So this discussion, what Anjali was telling, debate will go on, discussion will go on, and the guideline will change from 2001 to 217. Similarly, for the axilla, I will request all our colleagues to see the ASCO guideline that was published from the Ontario group. They have done a great job by recommending what to be done for axilla, for surgery, SNV, and also for radiation with or without NSCT. They have done a huge job, and that is a nice piece of paper that will be helpful for our colleagues for addressing axilla, especially after NSCT, which is a big debate now that what we should do. So with these few words, I think we want to thank our academic partner Healthcare who is supporting us, and hopefully next week, same time, we will be meeting to discuss about the contouring of breast cancer. Somebody believes it's not very important, but today in the era of RNI, not the breast, but the RNI contouring is really, even in PMRT, it's a big important thing. So hopefully we will be meeting next with faculties. John, Anjali will not be a regular faculty, but I will request if you are free, you can join. We have somebody else from Rajiv Gandhi to be with us. And thanks to Rajiv Gandhi for supporting us for this program. So I want to finish. I don't think that Haisar is with us. So with these few words, I want to finish the program today. Thank you very much. Thank you for joining. See you next week. Bye.
Thank you.
Sir, are you there?
Dr.
Sorry. Sir,
Goodbye, everybody. No problem. Goodbye, everybody.
sir, thank you.
Assalamu alaikum.
Sir.
Assalamu alaikum, sir. Thank you, sir.
Okay, bye bye, everybody.